These are therapies. These are therapies. So yes, you're absolutely right. DBT, and that is a higher level, more extensive type of therapy. There is a little link in the Blackboard video that the link does show you what DBT is all about. It's a tongue twister for me. Okay? It is a very hard therapy for me to wrap my head around. I like that cognitive behavioral therapy. I feel this way, let's talk about this, what can we do? Right? Whereas DBT is a little bit more advanced. It takes a long time. It takes months and years. And the person has to say, it's a commitment, right? It's a commitment. Anytime you join a group, it's a commitment. You gotta finish it, all right? All right. So, yes, and we're using mood stabilizers. This is lithium. What do you know about, my spelling is bad. You know what I'm talking about, right? The writing is bad, the spelling is bad. Do you know what I'm talking about, lithium?
A lot of side effects.
It's a mood stabilizer. So if you can walk around. Oh, absolutely. So these are the specifications. No different than any other med. You want to make sure it's a tight therapeutic range, right? Mm-hmm. So we take the toxicity level, right? Tight range. And what do you know, mood with lithium, it decreases the mood, so you get rid of that anger, that violent behavior, okay? Well, you have to monitor it, and you also have to, what's one thing, is you have to always check their electrolytes. The big electrolyte is sodium. So if they're drinking and peeing a lot, you're going to get rid of sodium? Yes? Does that make sense to you? You're drinking just water.
They feel more thirsty?
They feel more thirsty, okay? Drinking, if you're drinking more, you're peeing more, okay? So you monitor electrolytes. What do we have lack of electrolytes? Sodium and potassium. What do you feel like? How do your muscles feel? Tired. They don't ache, they tired. Everybody's tired. Muscle weakness, tired. Okay? So you need to make sure that electrolyte replacement is there. Monitor the levels. All of the others, will give you a little snippets of them throughout time, right? But what I'm interested in is what are you going to do as the nurse? Okay, that's what I'm interested in. And then, wait, before we get there, because this stuff is easy, here's the one page of therapeutic milieu. I posted it, right? All right? There's the one page. There's the components of any type of behavioral health setting. What's our goal, right? Our goal is to promote self-esteem, to promote healing, to have people feel safe in this environment. There's no judgment. There's collaboration between the therapist and the client, patient, right? Where it's respectful communication. It's pretty self-explanatory. Everybody's on the same page. So we have the nurse, the patient, the social worker, the pharmacist. How is it working for you as a patient? I'm going to ask. How's it going? There's one nurse that's this big person. Okay? All right, so this is pretty self-explanatory. I'm not spending any time on this. Right? Safety, healing, self-esteem, therapeutic environment, patient and the staff. All right? Safety. That means there's nothing to hang themselves on, nothing to cut themselves with, nothing to cause injury. So you have it whether it's in the therapeutic milieu in the outpatient department or inpatient department. All right, so outstanding characteristics. You have to recognize what the differences are, to recognize when you go, what's going on. So when we say borderline, right here, we have splitting. What does that mean?
Hot or cold?
What is it?
Hot or cold?
Hot or cold? Give me an example. Somebody give me an example, for everybody.
Like two people against each other.
Yeah, I don't get it from you, I'm gonna go to you. I always think good cop, bad cop, good mom, dad, bad mom, good dad. Right? If I don't get it from you, and then I'm gonna go to you. She was awful, do you know what she said? Okay, I only asked for a couple of privileges here, I don't understand why she said that. She's really bad, you're so good. Okay, how do you handle that? How do you handle that type of talk? Because that's what you're going to see. This borderline person comes in for a medical
Yeah.
hypertension, belly pain.
Like personality.
That other nurse, oh, can I get a little extra pain medicine? Or can I do this, or can I do that? And you say, what are you going to say? If you say no, they're going to say, oh, I'm going to try the next approach. Good cop, bad cop, right? So how are you going to handle that as the other nurse coming in? Now, feed into it, like what? What does that mean? Somebody else help her. I hear what you're saying.
Stick to the plan, what if
There you go. I hear what you're saying. I acknowledge the feelings. I hear what you're saying, but this is the plan.
Right, and they start talking about, I've got this, they talk about somebody who kind of just say, I'm not here for that.
That's not what I'm here for. They can't get what they want, what are they going to turn into? Angry, right? They're going to show signs of agitation. Right? How are you going to recognize? Going to go into you recognizing signs of agitation? We just talked about it. Right? Splitting. So that's splitting. Cutting. So the person's admitted because of cutting. Okay? Whether it's a suicide, or they're trying to, right? Trying to end it, or whatever. Okay, just for attention. How are you going to do if you're going to be taught? Are you like, oh my God? Are you going to be like this? No, you're going to be very bland. Okay, oh, I'm so sorry to hear that. The face. Pretty bland, clear cut, matter of fact. Very clinical. Okay? Very clinical. You're very clinical in many other situations too. All right? When you walk in the room and the smell is horrible, you don't go, oh, right? You don't do that. When you walk in the room and this horrible wound is festering and it looks so awful, all right? You don't do anything but let me know you to look at your wound. Right? You're very clinical, you're very professional. You don't walk into the room and it horrifies you some days when you see a patient so very thin, emaciated, bones sticking out, where, just thin and emaciated, or an abused person. You're very, it is, you need to deal with the situation at hand. Right? Okay, so very clear cut with the splitting limit setting. I'm here to do this. Clear cut communication, limit setting. Okay. That borderline, what do we have here? We have unpredictable, impulsive, manipulative. Unpredictable. So we don't really know which way they're going to go. Borderline on each border. That's how I think of it. It can be good. It can be bad. There's a lot of manipulation. Well, if you give me that, I think I'll do this for you. Would you do that for me? Would you do this? I'll do that. Manipulation. Okay? You said, let me do that. I don't know what to do. You feel guilty, right? They're not able to be alone. They search for relationships. They're lonely. they're looking for a lot of self-esteem, right? They're unstable, I use that word unstable, unable to learn from past mistakes. Do you think that person, look at your PowerPoint, I would use this as your study guide and look at your PowerPoint. Unable to learn from past mistakes. How do I think of that one? Unable to learn from past mistakes.
Like, I can't go to jail, I keep doing illegal activities, even though that, like, I'm thinking of, but, you know.
You have people in your head.
Yeah.
I have people dancing in my head all the time.
That they know it's wrong.
Yeah. That's right, and they continue the bad behavior. They continue the behavior that continuously gets them there. Okay? They're very reckless, they're unstable, they're intense. And again, I put all the words down. Use this piece of paper, because I did. I went back to the PowerPoint. This is what I did. I went back to the final PowerPoint and said, could they answer these questions? Right? And could you answer questions? My paper's full. Right? And I just type it up. Use it as a study guide. This is your study guide. Right? Because you have to go back to the PowerPoint to look at it. Do they have suicide? Yeah, you were thinking about it. Difficulty controlling anger? That's that commonality. Antisocial? Okay, wait, before we go there. So nursing intervention. Other than these therapies are good for all of them. You say these therapies are good for all of them. But for borderline, you want to limit setting, you want to set goals. What's your goal here? There's a plan of action, right? Are you going to allow that negative behavior to persist? Right? You're going to stop that negative behavior. You need to stop that behavior. That is not effective communication. That is not effective swearing. That's not effective communication. Right? Acknowledge your feelings. Be very matter of fact. Set the boundaries. This is what we're doing today, borderline. Setting the boundaries. Okay, letting them know the plan. I am here for. You are allowed to have 5 cigarettes a day. You have already had 4. Just letting you know there are 1 left. And we have 12 more hours to go. Just so you know. I'll say that just so you know. I didn't say just so you know. Just very clear-cut communication, right? Slide number 21, look at it. And that's up to you. I'm going to use this as a study guide. How many times did I say this? Oh, did I say it 3? 5. Oh, good, 5. Good. All right. Okay, so nursing intervention, setting limits. Biggest complications, violence, anger, self-care, self-harm. What do you do? Antisocial. If you haven't looked at it, antisocial, that psychopath, that sociopath, what do we have? So very inflexible, ruthless. I love it. Ruthless, lack of empathy, manipulative. Okay, do we see manipulative pretty much everywhere? Pretty much. Last one. Do we see as a result of all this, if you don't get what I want, I'm going to become angry? Oh, where's another piece of paper? Where's the handout? Okay, here we go. I'll bring it to you. I'm accommodating. I don't want anybody to go without having this. Right?
Oh, really? Were you late?
Did you get one? We'll go back now.
Oh my goodness.
Pass them down, pass them down. Anybody, hold them up, pass them down. Blackboard, there was a problem on Blackboard.
They're
There
looking
was
for
a
this.
problem on Blackboard. You need to call IT. Okay?
I
You need to
called
call
IT. We changed my password like
There's the
twice. I still can't get in.
announcements
Wait, so, because
So some people are like fine, but then like at least half the class like can't get in.
is it,
I know how to get in if you need help.
I changed my password and everything, called IT, and it like won't work.
Keep asking for a code, right?
Do you have the
Yeah.
the app?
I never had the authenticator, which is weird.
If you put the code, I'll show you how to do it.
Because like I think when it first started doing that, I downloaded this, but I forget when, and then it'll come up with a code for you.
Mine didn't even, I downloaded it and everything, it wouldn't do it. But there's another way to do it.
Oh, okay.
I'll show you how to do it. I'm gonna get to my comment. Don't put next. Just put use a different account and then put the same Comnet account and you should be in.
I'm in. It looks like I'm in now. So let me try.
I'll digest it.
Oh,
Okay. Antisocial.
I love that. I think John was
Antisocial, I hope you had a chance to look at the video. Ruthless, manipulative, no regret. No regret. Okay, they'll do whatever it takes to get what they want. All right? At all costs. You have many leaders like that, many bosses that you work with like that. Really, don't. There's only one objective, and it's their objective. To do whatever they need to have done. So aggression, is that aggressive? Aggressive behavior. They don't get what they want, they start to get a little agitated, aggressive. Are they superficial? Look, you know, time to your face, stab you in the back. Okay, they're not a team player. All out for themselves. The interventions, slide number 12, okay? You need to reduce those manipulations. How do you do that? Okay, how do you do that? How do you reduce those manipulations? You have to call them out on it. I see that this is what your goal is. I see this is what you want. You know, I understand, just to clarify. So here's that communication. You have to have strict boundaries with that person, strict boundaries with that person. All right, very strict boundaries. Let me just clarify, and that would be my thought. Let me just clarify. This is what the expectation was. This is what I said I would do. This was the plan, and this is the outcome. At this point, just keep everybody very clinical. Very clinical. They're easily angered, so you need to recognize those signs of anger and de-escalate. How do we de-escalate? We talked about it earlier. Same thing. You want a calm voice, clear communication, acknowledge the feelings, safety for yourself and the other person. De-escalate. So, you know, in my head, if you don't know what that means, you need to go back to that violence and look at that again. These are all interconnected like this, right? Money, right? Sometimes you have to really think about it. All right? Narcissistic. I love you, I love you, I love you. It's only for love. Okay? And they're looking in the mirror, and what the looking back is a tiger, a lion. Because if they don't see what they want, cat claws come out. And if you don't give me what I need, narcissistic, it's only me that matters. I'm argumentative, I can become hostile, I can sabotage, I can do everything in my power to make you look bad and me look good. It's only me that has all of the burdens of the world on my shoulder. Only me. And if you look good, it can cause me a little like, oh, something's wrong, I've got to get above you. You see it in the workplace, very difficult to have a relationship They become very, can go into a rage, can go into a rage. Okay, there's no need for a lot of stroking. Only they are good. And if somebody else is a little bit better, or they think they do, their accomplishments are a little higher, it doesn't make them feel good. Low self-esteem. Origins are lack of mothering, lack of a caring environment. Whatever the origins is, this is how we act. We can become very aggressive and hostile. You need to recognize the signs and symptoms of being angered, aggressive, hostile, and what do you need to do? Okay? They believe they're flawless, not need a lot of reassurance. Okay? They have to develop a realistic sense of self. Okay, how do you do that? That takes a lot of therapy, but only if the narcissistic person is aware of their behaviors and how they feel. So they have to first be accepting of what have they caused. They caused chaos in the workplace, in a relationship. So they have to recognize it in order to be accepting of therapy.
Are they
The best
ever going to
way-
be that?
Pardon me?
Are they ever going to be that? They think they're so great.
It's not an easy task. I'm never going to say never. I'm never going to say never, because you never know, right? It is all of these personalities are very difficult to treat. Extremely difficult to treat. Extremely difficult to treat.
Because they don't recognize
They
it?
don't recognize it. They just don't recognize it. They're inflexible. Say what?
To trigger somebody to act on
You look at, yes, that's right. They never seek treatment themselves. There's always a complication that gets them into there. Okay? So they may have trouble at work, a counselor may be brought in. How are you going to handle this person that's very narcissistic? You avoid confrontation. You have to basically, I want to say this, I mean, this is not the professional way to say it. If you're the coworkers, you got to shut your mouth and let this person right on top. Very difficult. So what happens? It causes chaos at work. People leave. Big turnover. The person stays. Everybody else leaves. You see it happen over and over again. Okay, very sad. Because that person still is there. And they just, because they don't recognize that they need help. They don't recognize it. They're resistant to change. They disagree, okay? Okay, yep. And only group therapy, CBT, DBT, all of these work, the therapies work, but it's a huge commitment. Years of commitment. You gotta go every week.
Is DBT something that works for things besides borderline?
Narcissistic,
So DBT is good for narcissistic and borderline?
yeah.
Okay.
And they can try it. Again, it's not one size fits all, you know? If CBD doesn't work, they try other. These are all the alternatives. There's no one set one. One drug doesn't work, they try another one. Okay? No one size. These are all the different types of therapy. They just approach it to different things.
Okay.
At that DBT, and they talk about the cutting, or you're going to hurt yourself. When people want to hurt themselves, you want to give them a tactic to use before they hurt themselves. And you go back to borderline, because that's what you see the most of. At least I see the most of. Okay?
Is the omega-3 fatty acids, could they be used for all of them or just for?
All of them. This is mood. Okay? It's good for cardiac too.
Yeah.
Okay? all right? It's all for mood. Tell me what I was saying. Oh, borderline. You see borderline mostly. You see those personality switches between the borderline mostly. So in that diet, the DBT, it's a tongue twister, I said, when before they cut, that DBT says, yes, I feel so angry, I'm so frustrated and angry, frustrated, okay? Because they won't listen to me, I'm gonna cut them, okay? And they cut them in that, all right? They cut themselves. But that DBT's therapy gives them some technique, it gives them a technique that before you cut yourself, what's going to be your plan? There's almost accepting of the fact that you're going to cut yourself or you're going to hurt yourself in some way. But the therapy says, before you do that, you're going to call me. You know you're making progress if they reach out. They reach out to another person. Or they substitute the pain in another fashion. So instead of doing this, they stick the film shows you they use ice cubes. They put their hands in ice cold water and keep them there until they feel pain. Because they feel so unworthy. That's basically the bottom line. They feel so unworthy. They do this, but before they do that, I'm going to say, I'm not worthy, so I'm going to hurt myself. So pain, stick your hands in ice cold water and keep them there. So they cause pain, inflict pain, injury. They're making progress if they go from cutting to ice cold water. They're making progress. I call that progress.
DBT, it basically teaches them what to do not to cut themselves,
And
or
an
it's
alternative for pain. They like pain.
But is that therapy after they cut themselves, or to prevent them from
Prevent
cutting?
them from cutting.
So it
It's
gives
an
them
alternative for
alternatives.
pain. It's an alternative. That means you're making progress. Okay? You're making progress. We could have done this. Now we're just using hands and ice. That's a good thing. Calling somebody is even a better thing. Letting people know is even a better thing. Okay? Yes, it's a way to let them change their behavior. So DBT therapy. We'll do more of these therapies, and you can look them up. I want you to focus on nursing interventions. Nursing interventions. Focus up. Don't go down the rabbit hole. Okay? So, all these therapies are very effective. Very, very effective. You have to find the one that works with that particular one. And the big one that stands out is alternative, giving yourself a different kind of pain than this kind of pain. All right, histrionics. Okay, again.
What's the biggest difference between DBT and DBT?
Oh yeah.
You look that up. I don't have time to look that up. Okay? I gave you that in my violence thing.
But I still
Okay?
don't understand it. I looked it up.
You need to focus up. We're not testing on therapy. You can look it up. Are we focused? Are we nurses? Are we going to the nursing here?
Yeah.
How do you recognize it? How do you assess things? How do you recognize it? And what are you going to do? You want to explore DBT or CBT, see me afterwards. So I want to get done with this for all of you. because Lisa Anderson is next. Okay? Histrionic. It's talk therapy and behavior modification. Good? Cognitive behavioral. What you're thinking, how you behave, what are you going to do? Okay? One size doesn't fit all. One therapy does not fit all. Group therapy. It's like, listen, I know, Weight Watchers. There's Weight Watchers helping you lose weight. Then there's Dr. Atkins. Then there's, go lightly as I want to say, Golo. Then there's Jimmy Craig. Then there's, you know, do you get the feeling, right? They have multiple ways to achieve the same goal. One doesn't work, you try the other. All right, so multiple therapies, but this is talk, behavior, action. All right, because it's here. Okay, histrionic. Last one. They want to be the center of attention, right? That's their goal, center of attention. So they will use whatever it takes to be that center of attention. They're very shallow in their relationships. And they'll do whatever it is to fluff themselves up to be that center of attention. And they need people to recognize them. They need recognition. They need recognition. They want to draw attention to self. They're concerned about personal appearance. They can be very seductive, sexual, flirtatious, demand lots of reassurance. What do you think they get? How do they feel if they don't get it? How do you recognize angry behavior? What are you going to do? How are you going to manage it? Setting boundaries? Right? Setting boundaries, clear communication, setting limits, direct, professional. All right, this is the plan. Okay. Questions, thoughts? I've written the words down for you. Those are the words when you think about all of these personalities. Okay? When I thought of that, these are dramatic, impulsive, erratic, desperate, entitled, manipulative. When you think of this, how you handle it, right? Lack of inhibition, sexuality, anything goes. Inflexible, it's rigid, rigid, rigid. Unpredictable, you're scared when people are unpredictable. Attention seeking, they'll do anything to get their thoughts. Lack of respect for authority, I think of automatically antisocial. Okay, antisocial, ruthless, do whatever you need to get it done. People have emotion regulation therapy. What does that mean? Remember, emotions, right? You're trying to regulate this impulse. So they're going to recognize they have this action, the impulse. They need to recognize it, and what are you going to do about it? If you tell somebody, if you have a partner, a therapist, somebody that you seek out, your best friend. This is heavy on a best friend, right? Right? You want to, I feel so angry, I could, blah, 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 blah. So what do you as a friend? Okay, take a deep breath. I know it sounds redundant. Take a deep breath, journal. If you want, and I'm used to, again, impulsive, I want to cut myself. Okay, then write down what made you feel this way. You have to think of what the trigger was. No different than any other medical condition. It's up here, what set you off.
I know that in a lot of the corporations, hospitals and so forth, I have friends in human resources, and they actually have called upon like psychologists and psychiatrists to formulate like a questionnaire, because they said that they can always teach the skills. However, if someone has this sort of personality disorder, it's extremely difficult in the workplace. And so they do these questions. They'll give you a long questionnaire, and based upon that, the psychologist can look it over and determine if there's any, sort of personality disorder there, and that could, the person might have the skills, but they won't hire them based on,
That's a slippery slope you're going down.
Yeah,
That's a slippery slope.
But a lot of because there's been such an issue.
Okay, but what is it? Do you see the bottom line is anger and coping? Do you see the baseline of it is anger, coping, no patience, no tolerance? Where's the bottom line, the root of it? So we have this, but how are we gonna manage it? Okay, these are difficult to treat because the person has to want to be treated, okay? Look at this emotion regulation, and then I'll read you anger, reckless, sad, depression, anxiety, and depression. How would you know the person is anxious? All right, that's Lisa Anderson, remember? Lisa, how do you know a person's anxious? Their behavior, not just physiological, okay? And sadness and depression are aggressive. What do you do for depressive? These are certain persons saying. So most regressive situations, restraints, right? When do you use those? We talked about that before. Review it. Seductive, superficial, sexuality, splitting, cutting, antagonistic. Okay? All these words, word salad for me, emotional processing. So we need to process how that person sees themselves. Okay? And narcissistic is I'm all good. You're all bad. You're good. Okay? I'm all good, and if you don't say that enough about me, the lying comes out. Self-centered, lack of empathy, and there's not a lot of empathy for any of these people, right? They don't have enough, how do you feel? Only interested in themselves, getting what they need. Right? I need a lot of love, borderline. I'm in dreams, you don't show me what I want. You're good, you're bad. Give it to me, I'm going home. Unable to learn from past experiences. Grandiose sense of self, that means, to me, antisocial psychopath. All right. All good. Manipulative splitting. Questions, thoughts. Cognitive behavioral therapy, great film on that. Gave you lots of resources. Okay, focus it up. The test is next Thursday. The blueprint has been posted. The test is next Thursday, a week from today, not Monday, next Thursday. I'll see you all, I'll see my group in the regular room. The behavioral lab stuff is posted. If you have trouble with Blackboard, call IT. They were here quite late last night. I was here quite late last night too, muttering to myself. Muttering to IT. You have a 10-minute break before Lisa Anderson comes down. Okay? Thank you very much. This is your study guide, along with your
Oh, it's in the nursing office. Your Dropbox space that online. The third floor. Can I see if you feel this? That is stop. You just pick time.
Related concepts, interrelated concepts. Thank you. And then the class learning objectives, I don't read those either in your syllabus. So political terrorism, what is that? Violence, yeah. It's a criminal behavior designed primarily to generate fear in the community, right? Fear is a big deal as far as political terrorism. I have two examples here of September 11th and then the anthrax in 2001. We're going to talk about that if we move into anthrax. But what other recent events do you guys know of that?
Extremists driving into mosques and killing people.
Extremists driving into mosques. What else? There's a lot going on, right? There's a war going on. Walmart. Naugatuck. That's not terrorist event, but there's a lot of violence going on, right? So,
like the Boston Marathon.
the Boston Marathon was one, right? 9/11. And then the following, the March on the Capitol. That's another political one, right? After 9/11, there was the anthrax scare, like 1 week afterwards, right? You guys remember that? What was that all about? After 9/11, anthrax in the mail. What was that all about? Remember? I'm asking you about recent history now, right? Letters were mailed out, right? And then they had to follow up with the post office. There were 5 deaths and 17 infections. But more importantly, it did its purpose. It created fear in the community.
Who was responsible for that?
I don't remember, to be honest with you. I think they did find somebody though. But then they had to go through the post office, like they had to go through everybody, and everybody was petrified to open their mail, right? That's the goal of political terrorism. Economic terrorism. What's that?
I remember from a long time ago, I remember when I was younger, somebody was putting needles or something with HIV, like somebody was sticking something like movie theater seats and
Was it a political thing though? It was probably somebody who was like sick, right? Mentally ill, right? But there's all sorts of, but that's another example of something that creates fear in the community, right? You're afraid, right? And that's what political terrorists are looking for. Economic terrorism is the financial terrorism. It is strictly defined to indicate an attempt on an economic stabilization by a group. Can be violent or not, it's usually not. But what are the implications for people there? What are the implications? What happens to people if there's an economic issue? There's an economic terrorism. Wall Street crashes. They get into banks. There was a one where they got into banks, right? They lose their livelihood. They may lose their jobs, right? And that creates, it has the psychological effects, and you need to make sure that people are able to cope. May create some PTSD. This COVID-19 resources I had up a couple of years ago just because, and it is part of the national stockpile, okay? I put it up a couple of years ago because we were totally virtual and we were in COVID-19. It's nice to know that stuff is still available. So what is it? What's bioterrorism? You guys tell me. You can read. Sure. Yeah. It's the use of them, though. That's correct. It's the use of microorganisms or toxins, right, to create disease. And there can be chemical, biological, radiation, or nuclear. The CDC website I have on here has all of them. But we're going to primarily concentrate on the biological ones. We're going to concentrate on anthrax and smallpox. Okay. So critical thinking, what do you need to do? There needs to be some surveillance going on. There's a lot of this in your book. Okay. You want to be looking for unusual clusters of individuals presenting with unusual illnesses in a single location. Right? Large numbers of people dying. Okay? You want to be, if any of this stuff, if you see this, if you see increase in morbidity or mortality, you want to make sure that you're notifying your supervisor, notifying somebody. Because you need to get personal protective equipment, you really need to know A and B, right? A, B, C, and D, you should know it, right? What is it? For A, it's for the category A of infectious diseases or mostly infectious diseases, right? You want to have a self-contained breathing apparatus, fully enclosed, vapor tight, chemical resistant, gloves and boots. It's the highest level you can go, all right? For B, it's pretty high, but it's less skin protection. You don't need a vapor tight suit, okay? It's chemically resistant though. C, you're looking at the purifiers, chemical resistant suit with hoods and gloves, and then D is your typical uniform. Here's a picture of the various levels. And level A is really what we're concentrating on. At level A as far as the organisms, right? Because we're looking at anthrax and botulism. Not botulism, what am I saying? Smallpox. Thank you. So when you're decontaminating, never assume that someone is decontaminated, ever. You want to make sure that they're usually labeled, right? There will be something on them that says there's decontamination. First step is to remove the patient's clothing, jewelry, and patient. These are patients that are in the area, right? You see up top a picture with someone who is in a suit, right? They do decontaminate the whole suit prior. So they may be going through twice. Okay? And the second step is soap and water wash and then rinsing the patient. Okay? You want to be mindful of the zones because not all decontamination happens at not a lot of, well, some of it does, but it may be happening out in the field, right? So you want to be mindful of that and what's going on in these zones. The hot zone is the first zone. It's the most dangerous. You need PPE. It's pretty close to where the disaster is. You give basic services. You're not decontaminating. You're making sure people are safe. And all contaminated supplies are left at the site, and then they go back and decontaminate them afterwards once they're finished. The warm zone is where they're actually decontaminating people. Rapid triage, PPE still. And then once their decontamination is finished, they can move to the cold zone, which is the support zone. You still need PPE for your triage, treating, and sending them where they need to if they need a higher level of service. Anybody work in emergency rooms? No? So are you familiar with any of this? Yeah. I only went to one disaster at one hospital. That was when the jail was, they considered it a disaster. It was Orange. The jail there was a riot. This was a little bit back. I tell you that all the time. I'm old, right? But there was a riot and I had to go to the emergency room. And so I needed to know, because that's not my level of expertise, right? I'm tele or med surg. So I needed to know exactly what they wanted to do. And I needed to tell them what I was comfortable with doing. Okay? So weapons and tier are nuclear, biological, or chemical, NBC. Nuclear is invisible. You measure it with a Geiger counter. Exposure is important, time, distance, and shielding. You want to decrease your exposure and your time and make sure you have some type of shielding. Make sure the people are contaminated. And just that there's examples where it's a dirty with these types of plutonium, uranium, and radon. Down the bottom is Geiger. A Geiger badge for radiation, and you will see Geiger counters used on, I'm not positive 9 still does it, but some of the units still have nuclear, little, what's called where they have things that are toxic, something that's toxic, and they will, scan the room. And nurses who go and need to wear a badge. Right? So that your level of radiation will be. People in the X-ray department wear these badges so that you know your level of radiation. You don't put pregnant people in there. If we can avoid it, you usually keep it close to your torso. Nuclear radiation is external or internal, and contamination spreads through direct contact of particles in blood and body fluids. So what do you want to do as far as nursing care? You want to wear your PPE? You want to triage outside of the hospital? You want to do the radiation survey with that Geiger, those Geiger counters? Decontamination that we talked about with soap and water. Make sure you bag those belongings. An internal, we'll get samples of the mouth, nose, throat, get a CBC because some of them are geared towards the blood cells. And then you can measure with measure specimens, the body fluid specimens. You do not need to know what the agents are for chelating. If they're internally decontaminated, then we'll give them some agents. I have it right here, and I'm going to tell you what they are because you don't need to know them, but just know that they may receive some. Okay? Questions? Pretty straightforward, right? Okay. Biological warfare. Biological warfare, what's this? It's hidden, it's covert, you don't know about it for the most part, right? And they're pathogens used to deliberately infect people. Usually the primary care provider will see the patients first. Many of the biological agents initially produce non-specific illnesses like flu-like symptoms like pains, sniffles. You gotta be aware of clusters in the surveillance. The health department will do, you report to the health department once you see these clusters. Agents are classified according to their highest concern. So level A is our highest concern again. Level A is easily disseminated, there's a high mortality rate, the risk is high, so we need to be prepared for it. And those are your examples. Concentrating again on the anthrax and smallpox. B is second highest, and then C is also easily translated. And they have a potential mortality rate, but we don't see them as much. And here's just the list, it's embarrassing. So anthrax, most likely biological agent available. Spores are forming bacteria in the cutaneous, respiratory, or GI. Early treatment can be effective, but it depends on the type of anthrax that that people contact. You want to make sure you're vaccinating animals and humans. Vaccination is huge for both anthrax and smallpox because it decreases the amount of disease in the community, right? And it may help patients as well. What's that? There is. For animals as well, and they're different, as you would think, right? Cutaneous anthrax is transmitted directly to skin contact with spores, fluid blisters. You guys can see these blisters here. There's localized itchiness and painless. The lesions are painless they don't look painless. That one. They don't look painless at all, but that's what I'm reading, right? That they're painless. Never came across anybody with anthrax, but it looks like it's painful. What's that?
Probably something that's released a little bit that comes in areas.
Could be. Yeah. So we want to make sure as far as our nursing interventions, that we get skin cultures, biopsies, antibiotics, wash with soap and water, and make sure they're on contact isolation. You avoid skin-to-skin contact with these guys. Anybody who has this. Respiratory inhalation is the one when you're thinking that there must have been something, there might have been something going on. It's usually weaponized, okay? Symptoms, again, flu-like symptoms you're looking at, the sore throat, mild fever, muscle aches. And then later on, respiratory symptoms are cough, chest discomfort, and tired muscles. And then severe, you're looking at respiratory Your nursing intervention, you want to make sure you vaccinate early, post-exposure. You may need to be thinking about shock interventions, and this is inhalation is the one where Cipro is proof has been effective.
Where what happened?
Cipro, respiratory. So you want to make sure you get that Cipro NIV as well. Respiratory inhalation. Gastric, anthrax transmitted through uncooked meat. Symptoms include nausea, loss of appetite, bloody diarrhea, malaise, fever, bad stomach pain. And it can lead to ascites and sepsis. There's a risk for systemic infection with gastrointestinal anthrax. The mortality rate is 25 to 60%. What kind of nursing interventions do you think you're going to be doing here? Supportive. Supportive. So what do you want to do? What do you want to? What kind of supportive nursing interventions do you think? Yeah. Fluids and electrolytes. Make sure they have their nutrition. What else? Antibiotics, absolutely. Treat it, right? Probably IV. What else? Pain medication. Yeah. What else? Possibly. Anything else? Oh, come on, I just said it. What do we want to do with anthrax and smallpox? Vaccinate early. And the antibiotics also here.
Is that still Cipro?
I don't think they're, yeah, I would believe so. It's the same bacteria, so. Smallpox. What do you guys know? Do you guys know anything about smallpox? History of smallpox?
It's coming back.
Tell me. What do you go like this? Tell me about it.
Well, quite some time ago, it destroyed, major population.
In the French Indian War?
What's that?
The French Indian War?
Yeah, it was a while,
Yeah, quite some time
a long
ago.
time ago, and then we fell.
And how was it used? It was used as political terrorism.
Yeah.
How was it?
And I think it was also used
They put it in the, who's that? You Googled it.
I did.
Good for you. They put it in the blankets, and it spread like wildfire, and it's no fun. You have one, this is a really like strong, right? There's a better word to use with it, but I can't think of it right now. Right? You have one case, you have an epidemic. You have an epidemic of smallpox, right? It's nothing to joke about. That's why it's one of your examples, right? So you can read the variola virus. Transmission is face-to-face. Weaponized is spread by direct contact with body fluids or contaminated items. These are the only contact codes. Symptoms, the incubation period is from 7 to 17 days. High fever, small red spots on the tongue and mouth to start off with, headache, body aches. Lumpy skin rash starts in the face and then it moves. Okay? And this is painful. It looks it. You'll see the pictures, but it does look it. Okay? And it's a pustular type of rash.
It's because the figure is so long that
So we want to support treatment here. We want to make sure we're medicating when we have fluids. We want to make sure we're medicating the pain. The antibiotics are for the secondary infection. Now this is a virus, right? So there may be some secondary infections associated with smallpox. So you want to make sure they get their antibiotics. And what else? Thank you. Contact with direct clothing and linen and droplet person to person. There's really not effective treatment. We want to be supportive. We want to give them O2, pain medications, like I said, fluids, antibiotics, for secondary infection. Cremation is preferred because it can live up to 13 years. The U.S. stopped vaccinating for smallpox in 1972, so a large portion of the population is not vaccinated for this. Now, okay? What are you laughing? Someone's laughing over there. Did you see something else, or?
No, it's just scary.
Well, yeah, and that's why we're playing a game afterwards, because I was like, this stuff is scary, but how often do you see this? How often do you see this? You don't see it very often. Last time we saw anthrax, I believe it was 2001.
Don't jinx it, please.
Don't jinx it.
I'm just giving you straight yes.
There was actually a case of anthrax in Danbury.
Oh, great.
When was that?
African drums. And he got it from the skins that were imported from Africa.
The animals, yeah.
It was a huge thing. It was bioterrorist.
It's not bioterrorism there.
No, but they brought in that whole teaching because they didn't know where it was from.
Right, and it
originally.
goes right back to the fact that we're saying that this is like, this causes fear. And that's why they're thinking, oh my God, is this a political act? Because they've used it before, right?
Well, not only that, but then the guy was ostracized in the whole community.
Well, we're gonna talk about that too, because there is like that psychological aspect, and we're gonna get into that. It's, of course he's ostracized, because why? We don't wanna get it. Everybody's like, oh, like, somebody, we had an emergency, in the emergency room, we had someone who had bed bugs, right? And, on their visit, and they came back, the nutrition student came back up and was like, ooh, we don't know what we want to do. Right? How close were you to her, right? Anything that's contagious is gonna, it scares people, right? That's not contagious, but you know what I'm saying, right? You can get the bugs on you. It's kind of, these are bacteria and viruses, right? So it causes fear, and that's why people are like secluded. In addition to the fact that we don't want to do that, right? Yes, you give vaccinations early on in order to prevent the spread. I know it's an epidemic, like you have one case, but you're still giving them early on, and it does assist a little bit with symptoms. Okay.
So no effective treatment means once you got it, it's just like trying to make them feel good until it's done, right?
Usually.
Except for vaccination.
Yeah.
And the vaccination doesn't really do anything about their current situation.
It should help a little bit with symptoms, yes.
So the vaccine for anthrax also to limit spread?
Yes. And help with symptoms. It's like all infectious diseases, really, you're right. This is a good discussion, it's like all infectious diseases, right? Viruses. It looks pretty painful, and that's the severe, so we want it for both, we want fluid valence infection, pain control, right? Think about body image, especially for smallpox. That was pretty rough. Respiratory issues. Isolation we just spoke of. Here's the difference, kind of compare and contrast the nursing problems with both. Any other questions? Biologicals? No? Yes?
Would you give them a Zofran, or is it better for them to roll it up?
If they have the gas.
If they're uncomfortable, you still want to give them Zofran, because what are they losing? Yeah, they're losing everything, right? And the continued vomiting can cause issues as well.
Yeah.
So, would you want them to get rid of it? Like, no, you're treating with the antibiotics and stuff. That's a good question. She asked if you want to give Zofran, you wanted to just throw it up and get rid of it, right?
Well, I was thinking about that.
Seems logical, but no, we're treating, right? We're treating and we're waiting it out, right? Yes.
Do medications help symptoms of smallpox?
It's pain, yeah. Pain medication would absolutely help with smallpox. That's the only thing that I can think of.
So like
There's no, Tylenol would probably help as well, but I'm thinking also because it's a skin issue, nothing like, you're not gonna put it right on that. Antihistamines possible. Yep. So next thing up, yes.
Are there places in the world that still vaccinate for smallpox or anthrax on a regular basis?
Not that I know of.
Christian.
There may be, you know, where there's, I don't know.
I would have seen someone had like 20 different shots.
You did?
Yeah, I don't even know.
They get a lot of shots.
That'd be something, that'd be interesting to find out. Who did? Are there?
Like the military.
The military, oh, that's a good, I'm glad you said that. I'm glad you Googled it. The military gets it, and also, you know, I get excited, right? I'm sorry.
They get everything.
Huh?
They get everything.
The military gets everything because they're exposed, especially to political terrorism, right? They're going in, right? But also nurses, a few years back when, one of my friends worked in the emergency department, and she goes, we're all getting vaccinated for smallpox. Because you're in the emergency department, so if you see it, you're gonna see it soon. And then you're gonna be going through all this process, you have to do everything, right? So nurses will be vaccinated in specific areas. I didn't get vaccinated because I was on telly, right? So, or not, yes.
And they use the same vaccines for pre and post?
Correct, I think so, yeah.
If somebody comes in with like those symptoms, like the fever, malaise, headache, do they automatically test for smallpox, or is it like an after, or what's the diagnosis?
Yeah, like the cultures automatically check for that.
I don't think so, not for fever or malaise. What will cause them to start testing?
The bumps, like
The bumps, what else? There's a cluster, there's a large cluster of it going on in one particular area, then you're testing everybody. You're doing your surveillance, right? You're seeing where there's a large cluster of people who have the symptoms. Was there a question there? Yeah, we're both vaccinated. Where do you guys? Jamaica, so now we know that Jamaica vaccinates. I'm vaccinated because I'm old. I am. Right? I am vaccinated. I'm already, you see it on your arm. You've been vaccinated, right? And it's like, and it's not comfortable. It's not a comfortable vaccination, but you want it, especially if you're in a country where you're worried about it, right? Thank you for that. I'm glad that's the point. Anything else, guys? As far as biologic? Yeah. So that's a good question. That's a good question. And local authorities, right? Usually have someone in administration that will report to the CDC. As a nurse, you're not responsible for that. You're responsible for telling, hey, your boss, hey, or whoever's running the ED. There's been a lot of people coming in with malaise, coming in with fever, coming in with these symptoms, like maybe they already see, the skin symptoms. There's a cluster here. This needs to be reported, so then it goes to the hospital administration. Good question. Anything else? No? Okay, chemical agents, nerve, vesicant, and blood. The nerve agents are the most toxic. They can be inhaled or absorbed through the skin. Lethal doses equal seizures, muscle paralysis. And treatment is specific to the agent. It is supportive treatment for nerve agents. The vesicants, an example is nitrogen mustard. You'll see some painful blisters, burning pneumonia, if inhaled. This was used in the vesicant nitrogen mustard was used in the Iraq War. It's interesting. Blood agents, we worry about their hemoglobin. We worry about those being destroyed. An example is cyanide. You're looking at headache, nausea, vomiting, tachycardia, tachypnea, seizures, cardiac arrest, respiratory failure. They have a hacking cough, right? They're pulmonary. They run into pulmonary edema that they need to be intubated. So preparedness, emergency preparedness is an act of making plans to prevent and respond and recover from emergencies. So anytime there's an emergency, we go into the 4 phases of mitigation, preparedness, emergency response, and then recovery. Mitigation takes place before and after the emergency to decrease the occurrence and reduce the effects that can be prevented. So, an example, like the mitigation phase is where you're thinking about, like say that there's a natural disaster, tornado or something like that. You're thinking about those good warning systems that go out, okay? And then, flood zones, if there's something going on, there's usually a warning. Preparedness is before the emergency and occurs, preparedness happens before the emergency and occurs to save lives. So it's really done through first response teams, okay? The Federal Emergency Management System, or FEMA, is responsible for preparedness. CDC, here's on a national level. American Nurses Association is a good source, because they talk about preparedness, and also the Red Cross, okay?
What was the first one you said before?
FEMA, Federal Emergency Management Agency, they're primarily responsible. Okay. The emergency response is really the hospital. It's Code Orange. Well, it's called the Code Orange at Waterbury Hospital. And I was telling you, I told you the story about when I had to go in. They call, and that's another point. I'm going to say that later on, right? You do not have to respond to this. You have to think about things that, they called me and I was like, I had little kids at the time, and I was like, I gotta go, right? So I wound up going, but you do not necessarily have to respond to it. Right? It's what is okay, what is good for you. You have to keep yourself safe. Okay? And it wound up being a really good learning experience for me as well. Like, I'm telling you what I'm doing and what I'm not doing. You want to be very clear on that and respond to an emergency like this, okay? You should know the emergency plan of your employers and your emergency plan of communities. The thought process when there's a mass casualty event is that you're doing the greatest good for all. What does that mean? Greatest good for all. Save the people who can be saved. So you're looking at reverse triage when this happens, okay? So the people who are black, and we're going to look at the color system tags as we move on, but the people who are black are going to die. This is a hard thing for nurses. This is a hard thing for anybody in healthcare, right? Who have, this is your life. You decided to save lives, right? These guys are going anyway. There's nothing we can do to save them. So you got to get that in your head. What does that mean?
The black.
The people with
What
the
do I
black
mean?
tag.
People who say there was a dirty bomb and they got hit. They were very close, right? You go up. They need to be coded. You go up to them. They were kind of close. They need to be coded. You got to move on because they're not going to make it. You look at them and you say they're not going to make it. They get tapped and slapped. And I know most of your face it's so hard to say that. But when you have a mass amount of people coming in, right? And there's some that are red that you can help. You have to go to the people who are red. You have to go to the people, right? You have no choice because you're not going to help the other people. That is an ethical thing that is so hard for people. I get that. I totally get that. But that's how it is when you're triaging, doing reverse triage. Okay? Like, what do you mean? I'm going to save everybody, right? When it's mass casualty and you have limited personnel, you have to think this way. What?
I said the most good.
Do the greatest good for all. Did you have questions first?
No, we were all looking at you because you were talking about them being coded as red or black. You just said black people.
Yeah, but black cat.
Well, we didn't know. She's really gonna die anyway, so why would you bother?
I'm apologizing to you. I did not mean, I meant.
I knew what you meant.
No, I didn't. Oh, no, I'm so sorry. I'm so sorry. When I saw her face,
I understood the same. Yeah. But it's also my fault I didn't recover.
I got a slide on, right? Black are people who are unlikely to survive. Red is immediate victims that can be helped in immediate intervention.
It's the next letter.
Yellow, okay, let me move it one.
Yeah, you gotta move it.
Thank you.
Mass capital.
No, it's not.
There's a slide.
It's like a couple ahead.
Next one.
Mass casualty.
Alright, since you're coming to go back.
There you go.
That one.
That one, yeah.
That one.
That's the one.
Those are the stats we're looking at, okay? Red are immediate victims that can be helped with immediate intervention. Yellow is delayed transport, can be serious, but it's not like, you know, likely to be life-threatening. You don't expect them to deteriorate over several hours. And then green is a walking wounded, they're minor injuries. I'm like, I'm still not over that. I feel so bad. I'm still not over that. I apologize. So we want some, again, this is a system to do the greatest good for all, based on where they're looking, where they're looking medically. Okay?
Starting with school with the reservoir.
Pretty much, yeah.
Wait, reverse triage, I thought you would start with the
No.
people who are.
We don't worry about the walking wounded now.
We don't worry about green or yellow.
Well, they're good, right? And the yellow doesn't need immediate treatment. So instead of black, we're doing red, right? But usually,
Well, yeah.
regular triage is we would go with, like, if we were triaging someone in an emergency room, we go with the black tag because there's only a few people there.
Okay.
Does that make sense? So, I just wanted to go back and see the strategic stockpile, you know about it, okay? You have all this stuff that I have posted up there. There's a stockpile of vaccinations, there's a stockpile of antibiotics, there's a stockpile of ventilators, there's all this stuff should we have a mass casualty event. Impacts for nerve agents. And the national stockpiles are usually close to the community, right? And the hospitals know where and all that kind of stuff. Okay? Interprofessional care, again, you want the relationship between the healthcare team and the community, all working together interprofessionally to, as a system, right? So the surveillance we talked about, federal, state, and local departments, hospitals, physicians and nurses, pharmaceutical companies, communication system. Communication system in general you need to think about, right? How does this usually communicate? And we're going to talk more about that as we get towards
Emergency broadcast.
Yeah, emergency broadcast system. Yeah. And how else afterwards? How else is your communication?
News.
Yeah. You really need to be careful that all communication is clear, concise, and accurate, right? You want your facts before you're telling people what's going on in an emergency, like a mass casualty, okay? So here's where we want to be aware. We want to decide, it kind of varies depending on the disaster or emergency, depends on the location, the number of people that are victims, the professional staff available. And again, your choice of whether or not you decide to participate is yours. Just know your skill set and your limitations if you're called into something, right? And you also want to know your scope of practice, right? Well, what can I do here in an emergency situation? That's all on the ANA website, okay? But don't do anything that you're not comfortable with if you decide to go, I got here and they were like, you're going to the emergency room. I'm like, okay. I can read the monitor, but you know what I mean? I don't know
time because they didn't have enough and all that, and some.
It was, that's the greatest good for all, and that's the reverse triage that we were talking about, right? And that's hard for, yeah, people did go to court for that, and you can be responsible. There is, you know that there is a Good Samaritan law, right? So, yeah, well, everybody's going to court. Somebody got sued the other day for not having, that they were to my clinical group.
Oh yeah, the mac and cheese.
Talking about this, but the macaroni and cheese, you can't be in the mess, right? No, really. So you went to court. Yeah, it's not, I don't know. It's not gonna be something, right? Like, so you guys are sitting, honestly.
So the food that you have
One of those kind of things, and you know your scope of practice, and you stay within it, you should be safe. And that's another good point, right? When you get out of here, let's jail. When you graduate, right? Make sure you get yourself insurance. You email practice insurance. Absolutely do.
Are there people that practice without?
I don't know. Yeah, the organization has it for you, and that's what I was told. I went to court once over a case because I was the charge nurse. And that's what I was told by the hospital lawyer. There's all this crap when something like that happens to you, right? You go with your manager, oh, your documentation's good, you're all set, everything's okay. That's all fine and dandy, right? That's nice to hear. But when you're going to court, and I wasn't the person who was being sued. I was one of the people who took care of I assisted the person because I was in charge. Right? So it's all fine and dandy to say, like when they said to me, the hospital has insurance for you. I'm like, I have insurance for me too. You should get your own, it's not that expensive. I still have insurance, bringing students into the clinical, right? Of course. I don't know what whoever's gonna do, you can predict consumer behavior,
No, you can't assume that the hospital's got your best interest.
Exactly, so that's a very good point. Let's talk to you guys about that.
Yeah.
It's not that expensive. A couple hundred or whatever, right? My husband pays it for me, so I don't know. I'm sure my husband's gonna take care of it. You want your house, you want to keep your house. You want to keep your belongings, right? You're going to work and taking good care of patients. You want to make sure that you're doing Okay, so you're going to do this. This is all in your book as well. If you want to look it over, it's all in your book as well. So let's talk about some lifespan considerations of people who are at risk. Who's always at risk?
The young and the
The young and the old, right? But also people who are exposed, severely injured or exposed to the incident, right? Eyewitnesses, first responders, medical personnel caring for a victim. You want to make sure these people get some type of, especially the first responders, right? Medical personnel, get some type of debriefing. There always needs to be debriefing after an incident. My husband was involved in, I tell everybody my husband's a paramedic, and he was involved in a case where a child was, and he had small kids at the time, right? Child was run over by a big, those big dump trucks, right? And he was exposed to that. And he previously had gone through a lot, it's emergency medicine, right? You see, you're in Waterbury, you're in Southington, you're wherever, you see a lot of stuff, right? He actually went through counseling afterwards, and there's nothing wrong with that. I was like, what, and had some PTSD, I believe, because it's a child, right? It's a child, right? And it's traumatic anyway, in general, right? So please don't feel, I had an incident where I had a patient, I lost a patient who we really were working very quite hard. He had just lost his wife. So he lost his wife and then he was in the hospital. And we were like, you just get attached to people, like, when you, especially when you're doing a lot of work and trying to, your best, right? And I went to my manager, I said, I gotta talk to somebody, this is affecting me, like, what could we have, and you want to debrief it anyway, why? To learn. There's two types of debriefing. There's a type of debriefing where you look at the situation and you say, what could have went better? And then there's a type of debriefing where you're like, oh, how is this affecting me? Okay? When you have cases like that or things like that, don't hesitate to talk to somebody. I know my husband, so like it's pretty good. Like when something happens, like we kind of talk to each other, and we never just HIPAA-wise, we don't name names or those kind of things, right? I have my husband, you have your significant others, but also if you feel that at some point, if it's that tragic or that difficult, get some help. There's nothing wrong with it. Okay? Why are the elderly more prone to difficulties? Because of the chronic disease, right? They can be worse and they're also, how much older they need, they have limited mobility if there's a natural disaster or even any of these. Very young, you want to make sure that you're keeping them safe and that they know that they're safe, right? Limit their use coverage. Assess for anxiety and PTSD on the elderly and everybody really. If someone has had a previous history or other traumas or stress, their chances for coping are decreased. So check, they may be decreased because of the multiple stressors, okay? So check their previous coping and check to see if that coping works. If it worked for them, okay, in the past. If it did, let's try and get those coping skills going again. Psychological aftermath. What are you looking at here? This all interrelates to what? Absolutely. So 3 months after the event, you want to make sure you're checking people. Okay? And you know that that they're coping okay. All right. There's the fear. There's the anxiety. Survivor's guilt, and as far as the death of a loved one or someone, on scene, responded to someone on scene, they may have survivor's guilt. Sense of great loss. They might be reluctant to express their feelings. Loss of self-control is here. And I want you to review those clinical manifestations of PTSD, please. They can be hypervigilant, they can have some panic attacks. Look at also the principles of trauma-informed care. You want to be mindful, and those are on page 2117. You want to be mindful of those concepts. We didn't really talk that much, right, about trauma-informed care. We just talked a little bit about it. I put a video up, which is excellent. I know it's an hour long. I can Google it. It's like, Professor Anderson, it's an hour long. I don't have that kind of time, right? It's excellent. It talks about what you need to know as far as trauma-informed care. This is considered trauma.
Where is this?
It's up on, it's in the discussion section.
In discussion?
Yeah.
Got it.
Yeah. And it's a specific incident, like, it's not a mass casualty or anything like that, but it's a specific person who really got trauma-informed care done. Okay? But know those principles, please. So factors that influence long-term adjustment, degree and nature of the exposure of the toxic contaminant, the magnitude of the trauma, the coping mechanisms is here to discuss, available resources and support, what the event meant in the first place, loss of a belonging, loss of a home, possession, the whole gamut, right? So you want to be mindful of that. Healthcare professional roles, you want to refer, you want to encourage them to enter social roles, identify normal stress responses, encourage talk, maybe talk therapy, and make sure there's a medical evaluation and treatment or improvement. So you should know all these things. It's just a summary of what we talked about. Questions? Yes. No? There's a lot of detox, focus on the nerve agents, and focus on what you're doing as far as in nursing care. Absolutely, reverse triage is a big deal. You know what it is, right? What else? Yeah. Nuclear, biologic, and chemical.
Oh yeah, but you remember my
You should know
son's
symptoms, yeah. It's
back
just,
then.
every one of them is not the whole thing. I kind of said that, right? I gave you the example of anthrax and smallpox.
I feel like these charts are probably better. They're probably gonna have
Right? Those are the ones that are most likely we would be seeing. That's what smallpox is. And you're like maybe.
I mean, it'd be smart.
Huh?
It'd be smart on their part.
It will be very smart, so you might see, and that's why they are the examples that I concentrate on. You want to do the greatest triage and a nutshell is do the greatest fit of all. Greatest fit of all, whoever you want, you have a chance of saving, you save them. Yeah. That's excellent. That's excellent. So 5 days of memorial shows reverse triage, and it also talked about PTSD relationship afterwards, where people had a heart. That is not an easy thing to do. First of all, you're dealing with a mass casualty, right? You're treating. Then you have to go in and say they're going to die. I'm walking away. They didn't have to go to court and explain and all that stuff. So that's why I really like again, get your insurance. Get your insurance. No joke. Because then, like, and there is, again, spirit in action. Technically, your hospital has insurance as well, but you need to get it as well because you might be called in. No, there is, you can't, the general community can be trained. General community, I'm not even talking about a nurse, because why? Because you don't have that many people.
I just love it.
It's usually paramedics, like emergency response people, that are doing all that, but the nurses can do it absolutely when they're coming into the emergency room.
No, these ones are.
I guess the nurses and the doctors were going back and forth, going back and forth. Like how many Chinese systems? Well, it was because it was an oxygen, he had other comorbidities or something.
And she brings another point up as well, is that the time you go back to the doctor, you want to be clear, right? And they're saying that you can't, you train, you need people to triage that way, to reverse triage. You want to be clear, but like, that is waste of time, as far as I'm concerned, right? It's waste of time. And then you're not like, I mean, you quickly, but you be concise about it. I think, you know, doc says, I think this is, maybe we should treat there. Right? Ultimately, it is tearjerky, it's tough. It goes back to that different.
She had a jacket and she was like this at my face. I was like, I'm like, no, so why do you need it? Like, she got pissed she's not with me. I'm like, I just need to know if my son no, you don't. She's like, yeah, you need to know that.
I've never seen anything.
And then she said, no, it's not anything. But I
You realize it's only 3 points on the final test, right?
But I understand that I'm not going to be like crying and going to therapy and just sitting and looking she literally like came over like right here, and she was like
Level A?
Level 8. Oh, then it's B. Highest respiratory. Yeah.
Nerve agent.
This is nerve.
Yeah, it is.
Hell yeah, it is, bro. Oh, that's where she got the answer right.
Nerve again? Nerve.
Nerve again?
You go, Ryan. You're so smart.
Wait, I'm confused. Just go back.
Yeah.
Well, it's too late. I know the answer.
You just started making me let me read it, so I went back.
It's too late, though. I already know the answer.
Sorry. Some people want to take it with
Isn't this in the slide though? No. They're not in the slides?
Ready? Here's a big one with a lot of words, so I want you to let people read it, please. You competitive folks, you type A personality stuff.
Smallpox.
How do you know?
Nuclear elevation. It is.
Yep, 100%.
Yeah, you give PPE and soap and water and you give back everything. I don't understand the question.
What kind of nursing for which agent? That's a nursing care for which agent? Radiation.
I got two.
Nuclear radiation.
That's the blue. No, that's the cold one. It's not rock, warm. Cold. It's the cold. That's the cold. Cold.
Oh, it's like, what is it? Hot, cold, warm?
This is